So, hello, my name is Jeff Taylor. We're here at the last day, the last afternoon of the last day of the International AIDS Society Conference in Kuala Lumpur. And I'm here with Dr. Judith Feinberg from the University of Cincinnati, who is chaired the session this afternoon on organ dysfunction. As people are living longer with HIV, they had the luxury of developing other problems, and that was the focus of this afternoon's session. And I guess tenofovir is a big issue, since more and more people are being put on tenofovir as they improve the quality of the regimens available throughout the world and not just in the Western world. And what are some of the problems we've been seeing and some of the things that were addressed?
Well, there is, as is true with any drug, once you get past the clinical trials that have very tight eligibility criteria and things are fairly homogeneous, when you start giving drugs to people by prescription who have all different other baseline problems or different genetic backgrounds, you start to see things. So I think we've always known that there's the possibility for tenofovir to be harmful to kidney function, and now what we're seeing with more extensive, longer use is that in fact it does really affect kidney function in a subset of patients. And in real world use, it seems to be more common and more problematic than was ever seen in the studies. So, you do studies so that the FDA and other regulatory bodies will approve a drug, but you learn much more about any drug once you're giving it to lots of people. So I think all of us in practice have seen the kinds of things that got described today. One of the really interesting things is as these drugs are moved more and more into the resource poor world, is that where people tend to be smaller and weigh less, is that the relative exposure, the dose is the same whether you're a 55 kilogram person or a 70 kilogram person, and that is at 2.2 pounds per kilogram, a very big difference in weight. So the study that came from India, where on average all of the patients weighed 55 kilograms versus the average American who weighs at least 70 kilograms, and at the rate Americans are going, probably weigh a good deal more than that. This is easy to manifest because everybody's getting the same 300 milligrams, but sort of less body parts to spread it around to. So I think that is something that people are going to need to take into consideration more and more. When various bodies write their guidelines, and there's guidelines for every country and region of the world, and now there's new WHO guidelines. In the United States, the tenofovir, as part of the combination drug Truvada, has been advanced in front of the other drugs in the same class as a quote-unquote preferred regimen. So an extraordinary proportion of people are getting this drug now in the United States. And there are certain characteristics that make you vulnerable to the problem. For example, any other disease that affects your kidneys. So people with diabetes, people who have high blood pressure, which is hard on your kidneys, African Americans who are just genetically predisposed to chronic kidney disease. All of those things, are pressures toward developing a problem with the drug. That said, plenty of people do fine with the drug. But what you're really trying to do is protect the smaller proportion of people who are going to have a problem. And as the research from India pointed out, in a more resource-limited setting, things like dialysis to support someone who suddenly has acute kidney injury and kidney failure is a very hard thing to come by. It's expensive in the United States, but it's not difficult to access if you need it. But that's a pretty extreme and pretty expensive way to cope with a nephrotoxic drug. So I think part of the issue of the future will be to try to figure out ahead of time who shouldn't get this drug. And maybe we can better sort out who benefits from, who is harmed. So I think that was part of the message. The other part of the kidney toxicity message was that There's an additive effect if you're taking a protease inhibitor and tenofovir, because protease inhibitors, especially ritonavir, which is used to boost almost all the protease inhibitors we use now, has its own slight nephrotoxic effect, but it plus the tenofovir effect turned out to be a significantly bigger problem than if people were on tenofovir and not getting a protease inhibitor, getting another drug, an integrase inhibitor or a non-nucleoside.
And atazanavir as well, right, was implicated.
Yes.
Yeah.
Yeah. Well, that I think the implication is because atazanavir, when you use it with tenofovir, must be boosted
yeah.
because there's a drug interaction between atazanavir and tenofovir. The other reassuring things about switching people, that was a second very interesting paper from Canada, from the group in Vancouver, and the interesting thing there was when people were switched because they developed kidney problems on tenofovir, their T cells kept going up, their viral load remained suppressed, and there were no sort of untoward outcomes from the switch, which was typically from tenofovir to abacavir, though not, I think, exclusively. So I think there have been some questions about abacavir in the last few years, and I think that was reassuring. Mm-hmm. That was kind of the kidney part of it. Then the rest of the session really dealt with problems with bones and fractures and bone density and cardiac issues, all of which, as we have the great good fortune to see people live with this disease, have become issues for long-term survival with HIV and HIV therapy.
Yeah, I think the cardiac stuff is especially concerning for people, especially as they approach middle age. As you say, we have the luxury of living longer, but have to face this. There seems to be kind of an accelerated rate of cardiac disease. And there's some fascinating studies presented. Would you like to perhaps address those?
Well, Ricky Hsu from New York did a study looking at carotid intimal media thickness. So for the non-medical audience, this is the lining of the carotid artery, which is the main artery from your heart to your head. And this is the one, if it gets gummed up, that's how you get a stroke. So that's a very important place to measure the development of atherosclerotic plaque, which is essentially what we're saying the intima thickness is. And we already know there's lots of things that adversely affect this, right? Too much cholesterol in your blood, history of smoking, high blood pressure. I mean, there's a whole host of things that we already know are bad for your heart. But the issue is, does HIV contribute in addition to that? And, there seems to be an accumulating body of evidence that, yes, HIV has some impact above and beyond what have been thought to be the typical risk factors for people who don't have HIV, that, doctors have been working off for many years. And I think the intriguing thing is, so how does that happen? How does HIV exert that effect? And is it just the HIV itself, or is it the HIV and the medications used for the HIV? And so I think in many regards, this is part of as well as the bone mineral density, is the same problem. We're sort of sorting this out. Is it the disease, the drugs for the disease, some more complex combination of the two? Because, of course, some of the drugs we use for HIV increase your lipids. And so if your cholesterol and your other lipids are not looking right, then drugs that make them look less right, can contribute to the problem. But there's also other organs in the body that are affected by HIV directly. So HIV can infect kidney cells and give you kidney failure. It's called HIV-associated nephropathy, one of these long, complicated words. So, the issue is, does HIV have a direct impact on cardiac muscle tissue or not? That wasn't the point of the study. The point of the study was to look at correlating the changes in the thickness in the carotid artery with all of these standard risk factors as well as with HIV. So they compared people with HIV negative and HIV positive, but all of the HIV positive people were treated. So you couldn't tease out what part of this is HIV and what part of this is the treatment. These were all, in fact, people doing very well, and they all had, undetectable viral loads. They were all people doing very well. So, it may be that the appropriate way to manage somebody is to, and this is going to be the next stage of the study. He just described what they're going to do in the future, but it may be that you have to keep ratcheting up how tight your control of things like cholesterol is. Like if you have HIV, maybe that means your cholesterol should be even more tightly controlled than if you don't have HIV. Right. And so the next stage of this study is going to be to prove that. But I think that appeals to a lot of people. I already tell my patients, no, 130 milligrams for your bad cholesterol is not adequate. But in the American Heart Association guidelines for people who don't have HIV, then, if you have only moderate risk factors, they'll accept that level. And I always tell my patients, no, I think we want to get to 100. And so that's what Dr. Shu was saying. Maybe we need to have tighter and tighter control so that whatever it is that HIV and HIV therapy add to the problem, you're counteracting by making the lipids that much better.
Right. Well, and I think HIV in and of itself is being described as a risk factor in and of itself, in addition to the traditional risk factors.
Yeah, that's been added now because there's so many studies that show that we have competition. There's so many studies now that show that people with HIV do seem to have vulnerability to heart disease above and beyond the fact that people smoke or are overweight or...
One, obviously, there are, as you mentioned, those are the controllable risk factors that patients can do something about. And those are always the highest risk factors.
Because you can do nothing about your age, sadly. And, you're either male or female biologically, and that doesn't shift either. So, being male and being older are both risk factors for heart disease.
And you can't change your parents. So.
No, you can't change your genetics. So, there are the smoking, the weight, the cholesterol. Those are the things that you have power over. And I think actually are very, very important things for healthy longevity with HIV. I spend more time in clinic now that almost the vast majority of my patients have undetectable viral loads and decent T cells. I spend more time trying to talk people out of their cigarettes than almost anything else. No, truly. And it's been that way for years because now people are having heart attacks and now people are developing lung cancer. And, there's a price that gets paid for health habits that are not ideal. So I spend a lot of time dealing with the cigarette. It doesn't help to live in a tobacco-growing part of the world, which is where I work. Kentucky is right across the river, and southern Ohio also grows tobacco. So, we're in the thick of it. But I think those are some of the issues. And I don't know if you want to talk about the bone mineral density part, because I think we're probably past 7 minutes, but it's up to you.
No, I think we should go ahead and wrap up. So thank you so much for taking the time.
You're very welcome. My pleasure.